Good morning and welcome to our webinar. I believe we have over 200 people joining us this morning, which is fantastic. You're all very welcome. And thank you for joining us for this really important conversation. My name is Veronica Gray. I'm the Deputy CEO and Director of Policy for Hourglass. And as you know, the charity is hosting this webinar to support independent researcher Amanda Warburton-Wynn as she launches her new report and research into the sexual assault of older people in hospitals in England. Hourglass provided support to Amanda back in 2021 when she published her first research paper on this subject, and we're delighted again to support Amanda as she today launches the follow-up. The research paper is now available on the Hourglass website, and following Amanda's presentation, we'll drop that link into the chat. I just want to run through some basic housekeeping before I hand over to Amanda, who will deliver a presentation on our key findings, and then we will move into a Q&A session. Please put all of your questions into the chat and we'll get through as many as we possibly can. I'm sure it's going to be a busy session in the Q&A this morning, but be assured we will give Amanda a copy of the chat content so she's aware of what discussion has been going on during today's webinar. The webinar is being recorded. A link to it will be sent to everyone who's registered. It will also be hosted on the Hourglass Knowledge Bank and shared in newsletters and on socials. We will drop in the link to sign up to the newsletter in the chat, and we would encourage you to join the conversation on social media. We'll drop the social media links into the chat shortly. As always, after the webinar, we will send out a link to a very short survey monkey to gather your feedback and give us some evaluation information, which is really important to us. We always encourage your feedback and we want to hear your thoughts. So without further ado, Amanda, thank you for giving us this time this morning. I'm really looking forward to hearing your presentation and taking the Q&A. So if you'd like to introduce yourself and then kick off with your presentation.
Thank you, Veronica. So thank you for letting me do this webinar this morning. And Hourglass have been really supportive with my research, with the last research paper, as Veronica said, and this one as well. So whilst I'm sharing my screen and hoping that it works, I'll introduce myself. So I'm Amanda Warburton-Wynn. I'm an independent researcher, consultant, and also trainer in domestic abuse and sexual violence. And I specialise in victims and survivors who are older people and people with disabilities. So hopefully the presentation slides have come up on the screen. Can someone just give me a shout to let me know? Oh,
yes, all good.
Thank you. As anyone who does these sorts of online presentations know, you can't actually see anything other than your slides. So as Veronica said, if you can put sort of questions in the chat, and I'm really happy to try and answer any questions at the end. So I want to start by explaining the reason why I have done the previous research and then have looked into it again. If anybody has heard me talk about the first research paper before, they will know a bit about this lady on the screen. So she is Mrs. Valerie Neal. Mrs. Neal was admitted to a hospital in Blackpool in 2018 following a stroke. She was just 75 years old. She, whilst in hospital, had a fall on the stroke ward, and then very shortly afterwards she passed away, and due to partly the fall and because she was actually recovering quite well from the stroke, it was decided to do a post-mortem to see if the fall had any impact on her sudden death, and the post-mortem actually found that Mrs. Neal's cause of death was from internal hemorrhaging. I can never say that word. internal bleeding from a sexual assault, and it was determined that the sexual assault had taken place whilst Mrs. Neal was on the hospital ward, on the stroke ward. We're now at 2014. There have been no charges brought against anybody for Mrs. Neal's death. There was a appeal on Crime Watch last year by her nieces, and also Crime Stoppers have put up a £20,000 reward, which is specifically aimed at staff who are working in that hospital in Blackpool, encouraging them to come forward if they know anything, because it is believed that the perpetrator of the sexual assault was actually a member of the hospital staff. So that's what led me to first starting to look into this, into Mrs. Neal's case, and I have put the link, and it will be in the slides that go out as well, to Crime Stoppers, so appealing if anybody does know anything. It's also worth mentioning that Mrs. Neal's inquest still hasn't taken place, and we're now 6 years since her death. So that got me looking into who else this has happened to in hospital. So the first piece of research I undertook in 2021, and I used Freedom of Information requests and sent them to all the NHS hospital trusts in England. And I was asking for data over the previous 5 financial years around alleged sexual assaults, specifically on patients aged 60 and over, where the alleged perpetrator was a member of hospital staff, and that included agency staff as well. So I was asking for the number of incidents, the sex of the victim and of the alleged perpetrator, the job role of the alleged perpetrator. I was particularly interested on whether the incident was reported to the police, and also whether there was any internal disciplinary action. So from that 2021 research, from over 200 trusts, I only got 46 responses, so quite a small response rate. However, that gave details of at least 75 incidents over that 5-year period. And I say at least because some hospitals withheld the exact numbers under data protection regulations. And some of them said that was because numbers were below 5. Some said it's because it was below 10. So I could only count 1 for each of those. But obviously, if they said it was below 10, that could actually be 9 incidents. So almost half actually withheld the totals on the data protection basis. And some that did provide data also only provided partial data, so they answered some of the questions and not others. But from that, those responses, I was able to get a bit of data. So it told me that the sex of the victim in most cases where it was given was female, and the sex of the alleged perpetrator where it was provided was generally male, although some of that data was withheld. So in summary, around the sex of the victim and perpetrator, as I said, some of the data was unknown or withheld, and also some responses said that the records they had were incomplete, so they didn't record age of or sex of victim or sex of alleged perpetrator in some cases. But as I said, where it was stated the victims were mainly female and alleged perpetrators were mostly male. In regards to the role of the alleged perpetrator, again, this was withheld in quite a lot of the responses, but the highest number was healthcare assistants. In terms of reporting the incident to the police, I did get a better response on this, and 28 incidents were reported to the police. But again, there were quite a number that said that they didn't know if the incident had been reported or not. Again, some responses advised that the records were incomplete or they withheld that information. I also got some sort of general feedback added to the responses around the incidents reported to the police. So of the 28 that were reported, 10 advised that the investigation was closed with no further action by the police. And also 18 of those, the other 18, said that whilst it was reported to the police, they didn't know the outcome of the police investigation. That was particularly concerning because it could have been that some kind of police action had been taken against the alleged perpetrator, but the hospital were not aware, so that alleged perpetrator could still actually be working on the ward with some kind of charge for sexual violence. I also got a few anecdotal comments added on there. So there were things like, we didn't report to the police because the patient had dementia. There was another one that said we couldn't find any evidence, so the patient must have hallucinated the incident. And also in quite a few cases where data was missing, it was because the patient couldn't actually identify the perpetrator. So from that 2021 research, as well as Hourglass kindly publishing it for me, I presented it to some safeguarding boards and also to the London Safeguarding Conference. And I know that it was disseminated amongst NHS trusts as well. And I have been giving guest lectures at Birmingham City University on their safeguarding master's course, and quite a lot of the students on that are actually working in hospital safeguarding roles. Cambridgeshire Police, which is the area that I live, did some updates to their guidance on managing crimes in adult care settings, and they specifically added things in around making sure that the incident is reported to the police, and also around reporting the incident to specialist support services as well. And I know that some NHS trusts did review their policies based on my research. So earlier this year, I thought, well, it's been a few years since I did the research. I'd like to get up to date data. So I set about with another lot of freedom of information requests. I did have some support this time from the Guardian newspaper, who have expressed some interest in this research, and they very helpfully provided me with some a list of contact emails for the NHS trusts. So again, I used freedom of information requests, but I slightly changed some of the information that I wanted this time. So I specifically asked, as well as information around the number of incidents and sex of victim perpetrator, role of perpetrator, I also asked about the location of the incident, also whether the incident was referred to the local sexual assault referral centre, and also whether there were any referrals or signposting to specialist support. The reason why I specifically asked about the last two, the SARC and specialist support referrals or signposting, was because in the first research paper, a lot of places said that they didn't refer to SARC because they thought that the patient had to actually go to the SARC themselves, and that often wasn't possible due to health or disability issues of the patient. But the first paper highlighted that SARC staff can actually come out and do forensics and other examinations on site. So I wanted to see sort of whether NHS trusts had sort of become more aware of that and actually taken up those services. I also wanted to ask about sexual safety policies. So the NHS England introduced sexual safety policies fairly recently as a response to, there have been several media articles around sexual assault in hospitals. Specifically, a lot of them have focused on sexual assaults in mental health inpatient settings. And that has led the NHS England to introduce some sexual safety policies, and also to introduce domestic abuse and sexual violence leads within NHS trusts. So I wanted to sort of find out a bit about the rollout of that. So this time I got a much better response rate. I got 148 responses from just over 200 requests. So much better data to work with this time. So this time I asked for data over 3 financial years rather than 5. And I had at least 274 incidents reported over that 3-year period. Obviously, that is a massive increase on at least 75 over a 5-year period. But it could be that that is due to increased awareness and better recording of incidents. We can't actually say that that's due to more incidents happening, although also that is possible. So 60 hospital trusts advise that they do have a sexual safety policy, or that it was currently drafted and going through approval processes. But there was some uncertainty around whether sexual safety policies are aimed at patients or staff or both. And when I investigated through NHS England and the actual sexual safety policies and charters on their website, it was hard to determine myself, really. It's not clear whether these are for staff, patients, or both. Quite a few trusts reference safeguarding policies and safeguarding routes as being the route that they would proceed down if an incident was raised to them, if there was a sexual assault incident raised. That was quite concerning. It's also come up in the 2021 research, because under the Care Act 2014, there is criteria around who is considered to be an adult at risk and who would then qualify for that adult safeguarding support. And a lot of trusts seem to be assuming that because the person was over 60, they would automatically go down the adult safeguarding route and be eligible for that type of support. And actually that isn't the case. Several responses also highlighted the PIPOT, which is person in position of trust, policies and guidance, which is the correct guidance that should be used, particularly where somebody doesn't meet the safeguarding criteria. And there was also, again, some anecdotal references and notes added, particularly around dementia, and the fact that some people with dementia have sexual disinhibitions. So in terms of the actual data, again, the sex of the victim were stated. The majority were female, and the majority of perpetrators were male. But again, some of that data was withheld or unknown. So of the reports that stated the sex of the victim, around almost 90% of victims were female, which is in line with national data on the sex of victims of sexual offences. But just under 20% of the victims were male, which is actually almost double the national rates. So that could indicate that older men in hospital settings are actually at more risk of sexual assault. So 85% of the alleged perpetrators were male. So again, the number of female there is slightly higher than we would expect from national data. So potentially more female perpetrators in these settings. And in regards to missing data, almost 70 didn't know the sex of the perpetrator, or it was withheld. In terms of the role of the alleged perpetrator, the ones that were reported, the majority this time were nurses. But again, an awful lot were other or unknown. And again, this this was often sort of little annotations next to it saying that the patient couldn't identify the perpetrator, or in some cases the system used to record the incident didn't actually record the role of the alleged perpetrator. So I asked around location of incident because I was interested about assaults on mixed sex wards. Obviously, mixed sex wards that you may know have been should be phased out, but they are still used in quite a lot of hospitals. So actually, the majority of incidents where the location was stated was on a mixed sex ward, although the single sex ward was not far behind. So it's quite hard to sort of determine whether that would have made any, whether that actually made any difference, considering we're talking about assaults from staff. So you're likely to have both male and female staff on wards. And again, in a lot of cases, the incident location was unknown. In terms of reporting to the police, had a much better response this time, and the majority of incidents were reported to the police. Although there were quite a lot, 65 were not reported. I also asked this time why the incident wasn't reported to the police, if that was known. And in a few cases, this was because the victim declined. They requested that the incident wasn't reported. But there were also a few that said that the incident had been investigated internally by the hospital, and they had determined from those inquiries that the incident didn't take place, so they didn't report it to the police. So around 63% of the incidents were reported to the police. In terms of referring to the sexual assault referral centres, only 13 victims were referred or signposted to those. 70 were not, definitely not, and unknown in 22 cases. In terms of either referring or signposting on to specialist sexual violence support services such as rape crisis and those kind of places, there were only 25 victims that were referred or signposted to those specialist services, and 57 were not. And again, there were, in some cases, this was unknown. We also have some anecdotal notes that were put at the sort of side of the responses. I asked around training for staff that specifically focused on the risks to older people around sexual abuse, sexual assault. And some of the notes said things like, we have training on people with dementia, and that explains that people with dementia have sexual disinhibitions, which is a bit of a generalised comment, really, that assuming that everybody with dementia experiences sexual disinhibition and therefore may make false allegations. Obviously, that isn't the case. There was also comments like, we are told that patients with mental illness make false allegations. Again, a hugely generalised and untrue comment. We did have one hospital trust, on a more positive note, who explained that they have their own ISVA, so their own independent sexual violence advisor, based within the hospital, who, when any incidents of sexual assault against patients or staff are reported, they are straight away involved in the team that investigate and support the victim around that incident. So that was really good practice to see. So when I looked at the incidents across both pieces of research, across the 8 financial years that I've looked at in total now, obviously the numbers for the the number of responses for the first research paper were significantly lower than the second one, but it does show an increase in reports over that 8-year period. So in terms of what conclusions I can draw from the research this time, as I said, there is a significant increase in reported incidents, so from around 75 over a 5-year period to 270 plus over a 3-year period. But this could be due to improvements in recording, improvements in investigating these kind of issues. It also appears that there is no national training around sexual violence against older people that is aimed at NHS staff. So that this is sort of a gap really that I'm highlighting. There is sexual violence and older people training available through Line Culture, which is specifically does training for ISVAs, for the Independent Sexual Violence Advisors. But I couldn't find anything specifically for NHS staff. Once again, it appears that victims are not routinely referred to the sexual assault referral centres, which is missing a huge opportunity to gather forensic evidence and obviously examinations, and also the support for the victim afterwards. And also not routinely referred to specialist support services. As I've highlighted, were issues around inconsistent recording of data. So some responses said they didn't record the age of the victim, some didn't record the location. So there was an awful lot of gaps in the data that was provided. And as I mentioned earlier, referring to safeguarding was often referenced as the policy that would be followed in such incidents, and that isn't always the correct policy to follow. So in terms of some recommendations, I am recommending standard recording of incidents and categories across the NHS to try and avoid these gaps in data. National guidance currently recommends that such incidents are reported to police, but there isn't a mandatory duty to report all incidents to police, and I'm recommending that there actually should be. It would also be useful to increase the understanding of safeguarding adults criteria within the NHS, and also to look at the alternatives to safeguarding adult referrals, such as using the PIPOT process. Just as I was finalising this research, the Victims Commissioner released her latest report, and in that she highlighted some of the failings around the criminal justice system for older people. And she actually makes a recommendation in her report that the CPS develop a strategy to improve the criminal justice experiences of older people. So I'm also, sort of echoing that recommendation, really. It would also be useful to consider either automatic referral with consent, or at least signposting to the SARCs, the Sexual Assault Referral Centres, and to specialist support. And I think particularly around where the victim may experience dementia, mental health issues, even though it may be determined that sexual assault didn't take place by police or hospital staff. In a lot of these cases, the victim is going to be convinced that it did. So that it doesn't mean that they don't need that support just because sort of no evidence has been found. And also around training, some national training around sexual assault against older people that can be accessed by NHS, adult social care, etc., I think would also be a very useful development. And then just at the end of my slides, I've got the link to the both research papers, which are on my website, and also, as Veronica said, they're on the Hourglass website. And just last month, the GMC have released some information and guidance for patients who are subjected to sexual misconduct by doctors. So there's a link to that there, but that does only cover doctors. It doesn't cover any other NHS roles. So I'm going to stop sharing my screen.
Well, Amanda, thank you for giving us such a detailed presentation on your research. I can only say I'm glad that you and I have been working together for a while, and I have seen the report before we launched it today. I'm glad that I had that bit of time to digest the information. It's really, really shocking and absolutely harrowing what you have uncovered. And it's clear that the system as a whole is failing older people, and we need to make that right. So we're now into our Q&A section of this morning's website. So we've had a bit of activity. I've been monitoring the chat. So one of the very first things someone has asked is, what age is an older adult? Now, in Hourglass terms, we work from age 60 plus, which is in line with the World Health Organization and their definition of older people. Amanda, do you just want to clarify maybe for us the age bracket you were working on?
Yeah, that is a really, really good question. So as Veronica says, Hourglass work from age 60. We also know that the majority of adult social care services for local authorities, that starts at age 65. Other places, so Age UK, I know their services start at 60. But there's also that consideration of maybe sort of, a few years ago, 60 was considered perhaps an older person. Now it isn't so much. Retirement age has increased, and people just, aging is just different nowadays. But I did start from age 60 on this particular research, as sort of trying to hit the middle ground between where adult social care starts and sort of older people's support services, really. So I did use 60.
Great, thank you, Amanda. And another person has just dropped into the chat. The FFLM are about to produce a guidance document about sexual assault in adults with cognitive impairment. Now, please forgive my ignorance. I am not sure what FFLM stands for. Do you want to give us any thoughts on that question, Amanda, please?
Yeah, so I know Elizabeth, who has put that post in, and I did speak to her about my previous research, and I can't remember exactly what FFLM stands for, but it is.
Someone has actually dropped in.
Yes.
Faculty Forensic Legal Medicine.
Yeah, so I'm really, really pleased to see that Elizabeth has posted that and the link to it. I think that will be really beneficial, so I'm very grateful for that.
Okay, great. Just another and a really straightforward one. Someone has mentioned in England we don't have an older people's commissioner. Is this just in Wales? Well, no, it's not. We have an older persons commissioner in Wales, and we have one in Northern Ireland. It is part of the Hourglass manifesto that we would have a commissioner for older people in England and in Scotland as well. So I'll just tick that one off the box. So Amanda, you mentioned that there's no national training for NHS staff, and there is some training available through Line Culture. Hourglass also provide training around all aspects of abuse of older people. Where does that need to go? What would you envision as the next step in developing a national training programme for NHS staff?
As I said, I think something that is available to NHS staff, but also potentially available to anybody who is working with older people. And I think it needs to some sort of training along that route would need to cover some of the specific risks that older people are up against when it comes to sexual assaults. So I think one of the things that my research highlights, and I didn't actually say in the presentation, is that there is often a presumption that somebody who commits a sexual assault against an older person, that is around some kind of fetish, and they perhaps there's a what's called gerontophilia, the sort of sexual fascination around older people is the issue, but actually, excuse me, it's around the power and control over another person, and an older person may be particularly vulnerable. So I think the training needs to highlight those vulnerabilities, but also, as with all training, I think it should also include some of the actual experiences, the lived experiences of older people, and something that either older people or victims themselves can be involved in developing this kind of training. But also, busting some of the myths, the things around, everyone with dementia has sexual disinhibitions. People with mental health issues make up allegations, and that's just not true. So I think there should be some, a training that involves experts around older people, and also the experts by experience themselves.
And I think that brings us nicely on to some of the questions that we've been seeing around coming in around ageism. Those assumptions that people have, assumed if the individual, you mentioned, it was assumed if the individual was over 60, it would just go down an adult safeguarding route. Why do you think, Amanda, that older people aren't being offered the range of options that are available to them as victim survivors?
I think a lot of that is because of public and professional sort of perceptions, really, of what a rape victim looks like. There is a term of real rape victim, which is perceived as it's a younger woman who is out on her own at night, may have been drinking, and is attacked by a stranger, sort of in a dark alley, and that is your sort of real rape victim. But when it comes to victims who don't meet those sort of, I guess they're a kind of media set criteria, really. Whether it's an older person or children, they sort of sit outside that expectation. So I think, and particularly with age as well, and if we're looking at something like dementia, I think there are often assumptions that someone with dementia who may have been sexually assaulted perhaps doesn't understand what has happened to them, or perhaps it didn't have so much of an impact on them as it would have done on a younger victim. So it's just not an automatic thought process that that person will need support. There are so many assumptions made, I think.
Yeah, and the whole real rape issue is one that we need to get rid of really, really quickly. I know in the research that Hourglass has conducted, we know the general public don't believe that older people can be victims of sexual assault and sexual violence, and it's just simply not the case. Which leads me then to, I suppose, a broader Hourglass point. We're very clear in our manifesto that we want to see a violence against older people strategy, which would complement a violence against women and girls strategy. We're very clear that there is a need for FOG strategies and services, but we also are keenly aware that as people age, abuse is less gendered, and about 40% of people that we deal with on an annual basis are male. So we need to see some inclusivity around that issue. When you talk then around presumed dementia and the link to sexual disinhibition, we have done some work around that as well in our polling back in 2020. It's a little bit out of date, but our research found when we presented the general public with a list of about 7 clear indicators of abuse, in the region of 20% of people said they're not indicators of abuse, they're indicators of cognitive decline. And I think that's really concerning, that there is this presumption that any issue that an older person has is automatically related to age. So my question then would be around, how does that reflect then whenever this older victim survivor is presenting to the NHS? Just like as in the case of Mrs. Neal, you know, that there was no recognition of abuse. It was all put down to age-related factors. How do we deal with that?
So I think in terms of NHS staff working with an older person, I think the main sort of priority for them is going to be the person's physical needs. And that's not just true for NHS staff. I think within social care as well. It's their sort of health needs or care needs are more obvious usually, and therefore it's usually easier to sort of put something in place to support around those needs, and things around abuse, whether it's sort of something that's happened recently or even historical abuse. They're sort of seen as a secondary thing, and it's often not recognised that actually those things link hugely together. The impact of abuse on somebody's mental health, and sort of whether it's mental health issues in an adult, or whether it's sort of dementia type issues, that abuse is going to be intrinsically woven and affecting their health and care needs, etc., etc. So I do think it's just that it is just seen as a secondary issue, and maybe it's not as easy to solve as sort of physical things are. So it just gets overlooked.
Okay. Another interesting question here. Concerned that some referrals did not meet adult safeguarding thresholds. Amanda, can you clarify what type of referral of sexual assault of an older person would fail to meet a threshold? And I completely agree with this question. It sort of beggars belief that it wouldn't meet a threshold for safeguarding.
Yep. So under the Care Act 2014, there is the term adult at risk, and to sort of qualify for an adult risk to meet that threshold, the person needs to have care and support needs. So it could be that those care and support needs are being met, but it also could be that they have care and support needs that are not being met. And due to those care and support needs, they're not able to protect themselves from the abuse. So it's actually quite a fine line, particularly when we're talking about maybe the younger end of the spectrum, a 60-year-old person who is completely independent, who works, has no care and support needs whatsoever, just because they may be in hospital for, sort of a quick day surgery or something like that while the assault takes place. That doesn't mean that they're going to meet that adult at risk criteria. Obviously, as a person gets older, it's more likely that they would have more care and support needs. So it's more likely that they would meet that threshold, but it shouldn't be assumed that because somebody is over a certain age that they meet that safeguarding adult threshold.
Absolutely. Okay, the chat is lit now, and I'm trying to juggle a lot of. So, a couple of questions then, Amanda, around. Yes, okay. Patient on patient sexual assault. Was there any allegations of patient on patient sexual assault, especially in the mixed sex wards, or did your focus go elsewhere?
So no, I was just focusing on sexual assaults by hospital staff. I think I mentioned at the beginning the Guardian, and I know they are planning to do an article around this sort of subject, and I know that they are very keen on looking at those patient-on-patient assaults as part of their investigations. But I particularly wanted to look at the sort of the abuse of trust, really. You sort of go into hospital, you think you're going to be safe, you sort of sometimes people in certain positions, sort of doctors, surgeons, can be elevated to some kind of untouchable status, that they're always a very good person, and actually highlighting that this isn't the case, really. I also want to say, I also saw something in the chat around assaults in care homes. With my first research paper and this one as well, I have been in touch with the Care Quality Commission. The first time, because I did want to look at assaults in care homes as well. With the first research, they said they were unable to provide the data because they recorded the number of incidents, but they didn't record whether the alleged perpetrator was a member of staff or another resident in the care setting, which was very concerning. With this latest research paper, I've again approached them and they haven't come back with a response.
Okay, thank you. Two questions just in, I think, that are particularly interesting. Was there any research shared about people with illnesses who are particularly targeted or are at higher risk? You had mentioned assaults on patients with stroke and dementia, but wondering if there's a higher percentage in one group over another.
No, I didn't delve into that. I think so. My research is undertaken independently. It's just myself. I'm not sort of funded to do this by any organisation or academic institution or anything. So I feel that my research just almost sort of it's just the headlines, really, and there is an awful lot more research that I think could be done around looking a lot more deeply into some of the issues that have come up, and yeah, sort of the specific vulnerabilities is one of the areas that does need more research.
Absolutely. I mean, you could make a career out of this issue, just drilling down. It's like peeling an onion and uncovering more and more layers. And when you ask one question and answer it, it leads to another. So absolutely appreciate that. Another question in, was any work undertaken around mental health facilities that include or cater for older people? There are often facilities adjoining hospitals, but entirely separate. And in Hourglass, we do unfortunately hear about abuse and neglect in those facilities. What's your thoughts around that, Amanda?
So using freedom of information request process obviously has some limitations. So I do know that some of so mental health trusts were included on my list. Some did respond and indicated that they did have units, spaces for older patients. But I didn't sort of do anything specifically around those units that aren't part of that NHS trust. So basically, if the NHS trust run that older people's mental health facility, that data would have been included. But if it was if it's separate or run by another organisation, then that data isn't in there. And again, that is another area that would benefit from more research.
I think on the issue of data, it is something that Hourglass is constantly banging the drum around. We have produced the Safer Aging Index for England and its regions, Wales and Northern Ireland. And not just because I'm from Northern Ireland, but I will say the Northern Ireland Safer Aging Index is the strongest document out of them all, because we had access to data that wasn't available or wasn't disaggregated by age in other areas. And in fact, we have been unable so far to produce a Safer Aging Index for Scotland because the information is just not there. So when we know the information isn't there, the data's not there, when we know, as Amanda, your research has identified, information isn't being passed on, it's not being recorded, when it gets to the police, it's not being disaggregated, there's massive issues. If it's not tracked, it's not fact, and we need a solid evidence base to move our work forward. So in terms of that, and you're mentioning that there are limitations with FOIs, is there an argument to be made around looking at GDPR legislation and making FOIs more accessible and more timely?
Yes, I think there is. Yeah, as you say, there is a huge gap in data around older victims of abuse. I think, one thing that I have mentioned previously around data is that that the main sort of mechanism for capturing data around abuse incidents is from the Office of National Statistics and the crime survey for England and Wales, and we've had age caps on that in the past that have only very recently been removed. It's going to take a long time for enough data to come through. We've also got issues of, as I found in this research, even though there should be standardised ways of recording data within the NHS, it seems that it isn't standardised. There seems to be the opportunity to perhaps not complete some sections on the data collection systems, and yeah, there there is a definite need for something that is, sort of a long-term data collection, something that can bring data from a range of organisations together, and also the accuracy of that data as well. The need to ensure that what what's coming from different organisations is accurate data. Again, I think that is another huge piece of work, a huge piece of research for somebody else.
Okay. Another couple of questions have come through. Yes. An acknowledgement that it's often impossible to get details about incidents via FOI. But this individual is asking, is it possible to know more about the incidents reported to see if incidents against older male patients were the same type of assault as female patients? And any ideas how this might be investigated further if we don't already know?
So again, the FOI didn't go into details about the exact type of sexual assault. Obviously, when we're looking at sexual offences, as set out by the CPS, there are different sorts of sexual offences and categorised into sexual offences and serious sexual offences. I didn't go down that route, but as I hopefully did sort of emphasise, that there does seem to be an increased number of older men that are victims compared to the expectations from sort of national across the board data. So there is definitely something to look into there around older men being at more risk of some type of sexual assault incident within. I think whether it's when it's in any setting where they may be in a sort of particularly vulnerable position, so hospital being one, but also I don't know, but I wouldn't be surprised if similar research around men in care homes also finds a sort of higher proportion of men at risk of abuse.
Okay, yeah, I completely agree that there needs to be a lot more research into the experience of male victims. It was really disappointing to see in your research, Amanda, that there was a lack of referral to specialist services and SARCs, and a lack of understanding really that the SARC team can attend the victim in hospital. So I suppose a couple of questions on that. Interested in your perspective. How do we address the lack of awareness of specialist support services? And I suppose even more broader, in a broader piece, how do we impress upon government the need for specialist services, that generic services do not work for older people? We have, certainly in Hourglass, I have experienced time and time again a real lack of understanding that older people have different needs in this journey to recovery than younger victims, and a sense of one size fits all, which we all know just isn't true. So where do we, how do we get that message out there that specialist services are essential? There is a right for older people to have specialist services. And how do we make older people as victim survivors, but also professionals, understand that they're there and available? There's quite a lot in that.
That's fine. So I think this pulls in some of the issues that we've already talked about. So older people are underrepresented in data from users of sexual assault referral centres and also specialist sexual violence support services. But that doesn't automatically mean that these things aren't happening to older people. It is partially that the data isn't there to sort of to prove it, which means that the funding isn't put in for these services, but also that those services just in a lot of cases aren't accessible for older victim survivors. So the whole thing about the SOCs actually being able to come out and do forensics, etc., on site. So many people aren't aware of that, and professionals assume that you'd have to get the person to the SOC. They would have to be, they would have to have, you know, there's sort of issues around mental capacity to consent, etc., and not really realizing that SOCs have experience and knowledge of those things, so actually they can enable the support still to be carried out. But I'm not sure how you can sort of get that message out with each. I mean, the SOCs across the country are run by different providers, so I guess it's a matter of those SOC providers sort of sharing information, raising that awareness that they can provide this support. They can provide support on site. They can work with older people. They can work with someone who has care and support needs, who has mental health issues, who has dementia, etc. In terms of specialist sectors, so places like rape crisis, etc., who we know are hugely underfunded. It's not that they're not able to support these people, they just don't have the funding to develop the specialist services and support that older people need. So yeah, again, it sort of goes back to the government being aware of the fact that this funding is needed, and also with older people, it can sometimes take longer, so sort of longer term services as well, not just sort of funding for very short intervention projects, but a longer term investment really in supporting older survivors to recover.
And I think that's an interesting point as well. We often would find in Hourglass that our intervention with an older person to get them to the point of recovery would take a longer period of time than for younger people, and I don't think that's ever reflected adequately or appropriately in funding of services because of that lack of understanding. From a research perspective, Amanda, what do you perceive is the next step in understanding? I suppose it's if money was no object, what's needed and what's essential?
So I think we have already mentioned data quite a lot of times. I think there needs to be much more research just done into older people and sexual violence, full stop. There are very few researchers who are looking at this issue, very few researchers that look at issues around older people and abuse. So sort of increasing that pool of researchers, and also understanding the lived experience of people. So research that can actually talk sensitively to survivors to find out the kind of things that would help them, would have helped them at the time. Yeah, I guess it is, as I said, mine's a kind of higher level look at it, but there are, as you said, so many sort of strands that sit underneath this that could form huge research projects on their own. And I think, but it doesn't seem to be a particularly attractive research prospect for a lot of people. You know, to look into older people and any sort of abuse, but particularly older people and sexual violence seems to be something that people just aren't keen to, you know, sort of research really.
Yeah, unfortunately, it really is still the last taboo, and we're so far behind the curve in the conversation around abuse of older people. this is where we were as a society 30 years ago, maybe more, in relation to child abuse. And we look at the success of charities in particular, and the campaigns that we've had. And it's just really, and I agree with you, it's really about changing hearts and minds and getting people to understand that this is a real live issue. Interestingly, however, we've had a couple of academics, I'm guessing, drop into the chat. One individual is looking at non-accidental injuries in adults at risk of harm. In this group, being cognitively impaired is a huge risk factor, approximately 90%. That's absolutely shocking. Really useful to know. And if that individual is still on the webinar, let's have a conversation. We'd like to give you a platform for your own webinar to discuss your findings. Another individual has posted, just finished research regarding disabled women and shocked at the levels of sexual violence. The assumption yet again is that sexual abuse just doesn't happen to disabled people. How do we change this? So it's not only age, obviously with age come additional factors, cognitive impairment, disability. It's so multifaceted, Amanda. How do we address all those different tentacles?
I think, as I've already touched on, it's around increasing the awareness that these things happen, but also I don't know if it's the right words, but anything around sort of sexual violence, disabilities, older people seems to be a sort of very unpalatable subject. It's something that we don't hear about in the media. As I said earlier, it's often sort of tagged as some kind of fetish, and in general, there's sort of assumptions that people with disabilities don't have sexual relationships, older people don't have sexual relationships, or a sort of general need to sort of back away from those conversations. And it's not until these things become just the norm and talked about more, like you said about with child abuse, that obviously in the past had been a very taboo subject, and it's sort of not to be talked about. And older people and people with disabilities and sexual violence is at that point now where it's kept as a secret. But I do think it needs to be talked about, not as a sensationalized, horrific issue, but actually something that is happening every day, and it's happening to people that people that we know, friends, family, etc., and sort of bring that conversation more out into the open.
Absolutely agree with that. And actually, someone has posted a comment. I think the storyline in EastEnders has been groundbreaking awareness raising, and I actually have to agree with that. I actually have worked with the EastEnders script writing team around that particular storyline of Yolanda being sexually assaulted by Pastor Clayton. And I do think that this issue needs to become more mainstream. We do need to see it on our TV. We do need to hear it on our radio programs. And it needs to be part of everyday narrative, so that people are aware, we can spot the signs and indicators, but also that older victims have their experience validated. We would get that a lot through the helpline, people contacting us and saying, oh, well, I'm not happy about it, but I don't think it's that bad. And actually what they're describing is very clearly abuse. So we need to give people the language. In fact, a couple of years ago, I don't know if it's still the case, but a couple of years ago, the oldest person that contacted the helpline was 100, maybe 101 actually. And she had found the helpline number while she was surfing, and she'd found the charity's website and started reading around what we do. and eventually made contact. And because what she read on our website resonated with her, and what she said was, I just realized that what my brothers were doing to me was abusive. I didn't know it was abuse. So it's about giving people the language that they can understand and own what's happening. I know we're rapidly running out of time. Let's see, what more do we need to learn in order to build services and to help us lobby better as well? Because we know that the current government has a pledge to have domestic violence within the next decade. We know that they have plans to put domestic abuse workers within 999 call centres. But that's not enough. We need the third sector to come in and pick up and deal with these cases. So what do we need to learn, and how do we build better services?
I think, as I've touched on in the last question, I think it was, there is a lot that we need to learn about older survivors of abuse. There is a symposium that the University College of London have set up recently, which is people who are working, or researchers, academics, who are working around the issues of older people and abuse, domestic abuse in later life. And Hourglass are part of that symposium. And there are around about 28, 30 people on that group. If that group was set up to look at, to include people who are working with children or younger women, and academics who are interested in that area of work, there would be much more people on it. So I think that there needs to be more people that are taking an interest in this. There's the whole, I guess, societal perception of older people not being as important as maybe younger people and children. That really needs to change. And people often see older people as an other, but we're all hopefully going to reach older age, and then we're going to be those ones that are being seen as other and not as important. But I do think as well that any funding into whether it's research or support services is so often put in as a short-term project, whereas it specifically when it's something for older people, and we just need to make that long-term investment, so that when me, others on the webinar reach, when we are older people, that support is there for us, and we don't sort of end up as an other and not as important as everybody else, really, or not as important as we were when we were younger.
Great, Amanda, thank you. So I think finally then, I've tried to keep the questions and things. So just finally then, looking at failings in the criminal justice system, really, what specifically do you feel needs to happen? We know that older people are often very reluctant to engage with the criminal justice system. And I personally have had experience of working with a victim where the police officer sent out to take the report actively tried to persuade the older person not to take it forward, even using the granddaughter as leverage in that argument. So from police officers who don't understand the issue, police officers who don't want to deal with the issue, we also, on a slight tangent, we have a lack of joined up thinking when it comes to sharing information between statutory services. We know of the individual who called 999, I think it was like 8-9 times in the 6 months before her husband murdered her. Right through then to the the prosecution services who fail to see that these issues are in the public interest, right through to the courts, where almost always the most lenient of sentences are handed down, most often suspended with community service and a slap on the wrist. Let's talk about the criminal justice system and what needs to happen and what reform is needed there in order for older victims to receive justice.
There's a lot I can say on this, really. I think that there have been so many reports recently about sexual offences in the criminal justice system. We know there's a very low charge rate, conviction rate almost minuscule, and also the stories of survivors and what has happened to them in court, how they've been treated by prosecutors, and that's if it even gets that far. And I know there are changes within the police with Operation Bluestone Soteria, Bluestone, whichever way around it is, to have more of a focus on the victim. And I think that focus on the victim does need to extend to the courts process, because particularly if you're talking about an older person, particularly somebody who may have dementia, or they may have they may not remember everything of that incident. You can just imagine them sort of standing in court and the defence absolutely tearing their account apart because, you have, like we've already seen in my research, that just reporting it to the hospital is, well, you have dementia, it probably didn't happen. Never mind before it, gets sort of in front of a court. And I think, as I highlighted, the Victims Commissioner has said that there needs to be an overhaul, and there needs to be much more of a focus within the Crown Prosecution Service on older victims and on supporting them to get that justice that they need. And I'll be really interested to see what the outcomes are of that recommendation. But I do think that it does need a big overhaul, and it's not just older people, it's people with learning disabilities or physical disabilities, mental health issues, etc. That criminal justice, whilst it's only going to be a small chance that they may get it anyway, it just decreases with every additional need that the victim has.
Yeah, I completely agree. We can think well, in my head, it's only about 3 or 4 years ago. It could be 2018 now maybe 2019, that we had the inspection report into police and fire and rescue in England and Wales. And that report was called The Poor Relation. And it just makes perfect sense. But it's an alarming indictment that there could be an inspection report called a poor relation, because police and fire and rescue have so little regard to the experience of older people as victims of crime and abuse. Okay, we need to start wrapping up now. Amanda, someone dropped into the chat earlier that you had a piece in the Journal of Adult Protection back in 2022. Now, I have to say, maybe I was aware of it, but do you want to just mention what that's about and how maybe people can pick up on that?
Yes, so it was Bridget Penhale that put that in the chat. It was basically it was based on the first research paper I did, and summarising the findings of that. But it was a more of a practice paper suggesting how the things that professionals could do to try and stop these things happening, and really with a focus on both the criminal justice element, but also the specialist support to older victims of sexual violence as well. I will do a little plug and say that I am on ResearchNet, and I have all my papers are available on there. Everything I've had published, which isn't lots, so it makes it sound like it's hundreds, but there's a few on there, so that's all accessible on there.
Super, Amanda, thank you. Maybe separately we'll get that link from you and circulate it. We have a lot of people wanting a conversation, so it's really, really useful. Amanda, I think it's clear from the number of people who registered for this morning's event, the huge level of engagement that we've had in the chat, and the overwhelmingly positive feedback that we've seen in the chat as well. This subject has really touched hearts and minds this morning. You have informed us with robust research. You've given us a narrative that has ignited a call to action. The final question today, and it's one from me. How can we help? What one thing would you ask everyone on today's webinar to do now that we're better informed and more aware of the vast array of issues that your research has identified?
I think I would have two asks, actually. The first one would be, I've seen some of the comments in the chat asking if I've covered particular things, highlighting victims with learning disabilities, cultural backgrounds. We had the question about male victims. And as I said, my research is just touching the surface of all this. So if anybody is interested in doing any kind of research and has the ability to do so, please do. And that there are organisations that will work with you and help you to get the work published, like Hourglass have kindly done with me. But on a sort of more personal level, I think the ask would be that if you suspect a sexual assault, if somebody discloses one to you, the first thing we should all do really is believe that person. Don't let these sort of things around, well, it could be the dementia, it could be mental health, it could be because they're under anaesthetic. Just shut those voices out and believe that person, and investigate as if it's an older person, as just forgetting that it's an older person, as if that was just, I guess yourself really, or a friend. How would you expect that to be investigated if it was your own case, really?
Yeah. Challenge accepted. Excellent, thank you. So in closing this morning's webinar, I'd like to thank everyone for taking part. I'm sorry we didn't get through every specific question. I did try to group questions and themes. We really appreciate your engagement. As I said earlier, we will export the chat and give it to Amanda so she's completely aware of everything that's happened, and some people have left contact details. Your feedback link should be in your inbox in the next few minutes. And Amanda, thank you for your research and for shining a light on such an important yet still taboo subject. And we look forward to working with you to continue to promote your research. I will just say Amanda will be back joining us on the 30th of January for another webinar dedicated exclusively to sexual abuse of older people. So we will have Amanda talking again about her work and the impact of this new research. And we will also be joined by experts in the sexual abuse arena, including some of our own ISVAs from Hourglass. So that's Thursday the 30th of January, and you can book online now. So for today, thank you all very much and have a good rest of Thursday. Take care.